Good afternoon, everyone, and welcome to UCSF's Family and Community Medicine Grand Rounds. We have a wonderful speaker today, Dr. Kevin Fasella, who is going to talk to us about why defining health is radical, implications for health, equity, value, and national health. But before we get to hear our main speaker today, I just have a few of the usual housekeeping announcements. The first one that you probably figured out is that this session is being recorded. If you'd like to view today's session or other prior grand rounds, you can just check out our UCSF Department of Family and Community Medicine website. Everything is uploaded on YouTube, as this session will be probably a couple days from now. I also, as always, want to say a special thanks to our tech team, to Roy Johnston and Benjamin Wallen, without whom this session would not be possible. Our goal is to make our grand round sessions interactive. So I would encourage you to please use the Q&A box to type in your questions or your thoughts or your comments, and we will read them out to the speaker, to Dr. Fasella, and let him respond to them. It's really wonderful to hear everyone share their ideas. This is such a generative group, and it's exciting to see and hear from everybody and get input into the sessions. Also, if you have ideas for future grand round sessions or just thoughts about how we should be handling things in general, please feel free to give us feedback either by emailing us directly, or we have an evaluation form that we will put at the chat at the end of the session. So with no further ado, again, I want to welcome Dr. Kevin Fasella today, who will be speaking about why defining health is radical, implications for health, equity, value, and national health. Concepts matter. There is a current political struggle in the US over the meanings of race, racism, and wokeness. In this presentation, Dr. Fasella will argue that defining health itself is a radical idea, and that the meaning of health has profound implications for how we organize research, healthcare, and ultimately society. For this reason, our nation has always avoided defining health. This definitional void yields a default of disease-based biomedical definitions of health. And the consequences of this default definition are profound. For example, enabling research and healthcare funding that supports the biomedical-industrial-healthcare complex, also obscuring deeper meanings of health equity, trivialization of social determinants of health, marginalization of primary care, and certainly contributing to unprecedented declines in national health and well-being, as well as perpetuating gross inequalities and inequities of health. The concept of health has profound implications for what it means to be human, to care for self and others, and for the social conditions that enable people to optimize their full health potential. We need a national dialogue on the meaning of health, and critically, how to enable it through research, healthcare, and societal change. Dr. Fasella is going to help engage us in that dialogue today. He is a professor in the Department of Family Medicine at the University of Rochester School of Medicine. He's co-director of the Department of Research, the Research Division, and the co-director of Equity-Focused Dissemination and Implementation Core within the University of Rochester Clinical and Transnational Health Science Institute. Most importantly, Dr. Fasella has worked as a family physician in FQHCs, caring for multi-generational families for 40 years. And we are really excited to welcome him today. Thank you, Dr. Fasella, for joining us.
Well, thank you very much for having me. I very much appreciate the honor. And I think that's a great, that was a great introduction here. Let me see if I can get these slides to move here. Oops. So I think that's a pretty good background. So I don't think I really need to do an overview, but instead what I want to do is just provide a little more context in terms of how I came to think that the meaning of health matters. I can tell you that in my younger days, I thought that this was a little bit of an arcane discussion. And now that I've gotten older, I've come to the opposite conclusion. I originally went into family medicine very much because I wanted a holistic view of health and treating people as whole people instead of diseases, and that was a key motivation for me. I trained at the University of Buffalo, and then, as Margot mentioned, I went into practice at an FQHC. I was there for 9 years, and then 7 years as medical director. And while I was working there, I began to wonder, how does health get under people's skin? Why does poverty and racism matter so much in terms of health? And that motivated me to go back and do a primary care fellowship in Rochester, where I am. And I really felt privileged to be able to do that, to be able to take off for 3 years, and it worked out for my wife as well. And we moved to Rochester. And there I was surrounded by just wonderful mentors, including George Engel, who we'll talk about, the originators of self-determination theory at DC, and Rich Ryan, multiple experts in patient communication, including Rich Frankel and Tony Suckman, Tim Quill, Howard Beckwin, and then health services research and health inequities with Peter Franks and Al Muslin, as well as work with Harriet Kitzman and David Olds, who developed the nurse family partnership. So it was just a real blessing to be surrounded by these people and to really think deeply about issues. And my beginning of my career really focused very much on understanding the micro and macro determinants of health. Really before it became a buzzword. And then around 2000, I began to focus more on inequities within healthcare and the concept of using quality improvement to address these inequities, and got involved in a lot of national work and ways of helping various healthcare organizations really implement strategies to address the healthcare inequities. But over time, I have gotten frustrated with both the pace of progress, but also the metrics that were being used. And when I began to think more about it, I realized that it's more than just a measurement problem, that it's really a paradigm problem in how we defined health. And so that led me to thinking more deeply about health and how it's defined, particularly in the United States. So, we could retitle this, of course, the biomedical model of health, looking for health and love in all the wrong places. Many of you may have heard the term weird. Certainly the biomedical model is a weird construct in that it's Western educated, industrialized, rich, and democratic, comes from a democratic country, as defined by Joseph Henrich. And it really emphasizes, of course, the individual as really detached in time and place and person, emphasizing their autonomy and independence and self-sufficiency. And of course, many of you know that indigenous North American peoples have a slightly different view of that, and emphasize balance among the physical, emotional, mental, and spiritual components of self, as well as the importance of interconnections among people, communities, and land. And a similar approach in many Eastern cultures who emphasize interdependence, family, and community relative to the individual. I think when we think about the biomedical model, these are sort of the core constructs. Obviously people have tried to adapt this and modify it to some extent, but I think that these core suppositions still hold, which is health is the absence of disease. It's very much a disease-based model. Disease results from mechanistic dysfunction. Removing that mechanistic dysfunction will restore health. And as a result, we're like cars going to a mechanic, or if we can find what's wrong and fix it, we'll be done with it. And it really doesn't require too much agency on our part. Scholars trace the origins of this to the concept of germ theory, where you identify a germ and develop an antibiotic to deal with it. And of course, Louis Pasteur and Robert Koch with the Koch postulates for those in medicine. The second component really comes from Rudolf Virchow, who is regarded as the founder of cell biology. And I'll read some of interesting quotes from his work. Cellular pathology is not an end if one cannot see any alteration in the cell. Chemistry brings the clarification of living processes nearer than does anatomy. Each anatomical change must have been preceded by a chemical one. And then he goes on to say the body is a cell state in which every cell is a citizen. Disease is merely the conflict of citizens of the state brought about by the actions of external forces. It's kind of interesting coming out of that century from him. But probably for those of you who are familiar with Virchow, he is also considered the father of social medicine. And he wrote, if medicine is to fulfill her great task, then she must enter the political and social life. Do we not always find the diseases of the populace traceable to defects in society? And also the real care of the health of an individual must always be rooted in the small circle of personal friends of the family or the community. So although he was the founder of cell biology, he was clearly using a systems view for health. I think very much in reaction to the growth of the disease-based model, the World Health Organization developed its constitution in 1948, and of course, antibiotics had already been developed for penicillin, sulfa, to treat various infectious diseases, and there was lots of enthusiasm, of course, for the biomedical model. And the World Health Organization developed this often quoted definition: health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Now, people, of course, have quibbled with the complete and so on. But really, the point was to emphasize that health is much more than disease. Larson published a paper using a genealogy approach to really look at where the origins of this definition came from. And he, looking at archival materials and quotes, it actually turned out that the origin of the definition came from Henry Siegrist, who was a medical historian, and I think the second chair of medical history at Johns Hopkins at the time. And as you see, he made the cover of Time magazine and was often in conflict with the AMA. And he had written in 1941, in such a society, health means more than the absence of disease. It's become something positive, a joyful attitude towards health. And some of the writers of this, including Raymond Gautier, appeared to have borrowed some of this language from him, and probably for obvious reasons didn't want to necessarily attribute it to him. Henry Siegrist had been a strong advocate of universal health care, and actually wrote a report for the province of Saskatchewan in Canada, and developed a Medicare for all within that province that eventually became a model for Canada. And the preamble to the WHO Constitution, I think, gives you a better idea of what the framers were thinking. Right after the definition, the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic or social condition. Remember, this is from 1948. Healthy development of the child is of basic importance. The ability to live harmoniously in a changing total environment is essential to such development. And last, governments have responsibility for the health of their peoples, which can be fulfilled only by the provision of adequate health and social measures. In Larson's article, he asked the question, well, how did the US ever ratify the WHO Constitution? Now, this was post-World War II. anti-communism was on the rise. What led to this? And he points out that President Truman stated in his health address to the International Health Conference, or the Interim Health Conference, which preceded the WHO, the right to adequate medical care should be available to all people. For this objective, I can assure you the interest and support of the United States. Obviously, President Truman thought that universal health was coming to the United States and was prepared to support it. But the AMA at the time, of course, was very much against universal health, and they lobbied successfully for a clause to be added in congressional ratification that nothing in the Constitution of the WHO in any manner commits the U.S. to enact any specific legislative program. And then in a number of years later, because that was 1948, now we're up to 1977, George Engel, who, as I mentioned, was actually teaching and making rounds when I did my fellowship, and I rounded with him, wrote this article in Science, which has now been cited nearly 20,000 times, and it really is a classic. And I encourage anybody who is interested in a really detailed and scathing critique of the biomedical model to read this article, which is widely available. And in 1986, at the Ottawa Charter, the WHO elaborated more clearly on what the meaning of health means. And I think many of these concepts have really been incorporated subsequently into a more holistic definition of health. And they said that health promotion is the process of enabling people to increase control over and to improve their health, to reach a state of complete physical, mental, and social well-being. And an individual or group must be able to identify and realize aspirations to satisfy needs and to change or cope with the environment, that these are all important constructs. And then they go on to talk about social determinants of health, including peace, shelter, education, food, income, a stable ecosystem, sustainable resources, social justice, and equity. So clearly, the WHO had a holistic view of health that very much built on human rights, and with full acknowledgement, even back in 1986, of the critical role of social factors. Vera Huber convened an international conference to sort of reach a consensus on this in the Netherlands, and came up with the definition of the ability to adapt and self-manage in the face of social, physical, and emotional challenges. And that appeared in the BMJ. Gregory Mackel and colleagues surveyed the US population, and I gave them various ways of defining health. And as you can see here on the slide, that really it came down to 4 different factors. So a capacity or capability of living an active life, ability to have control, and to be able to enact behaviors, including self-management. Of course, the biomedical model, and then a psychosocial model that includes the various dimensions. In a more recent scoping review by Van Drutten, she and her colleagues looked at everything that had been published on health, and again came up with a very similar sort of list, suggesting really that health is a multi-dimensional construct, and that people emphasize different facets of this multifaceted concept. I think most of us will agree that a disease-based biomedical model continues to dominate, particularly in the United States, but even in much of the weird cultures. If we look at NIH research, which now has a $50 million annual budget, NIH institutes often have diseases in their name: National Cancer Institute, National Heart, Lung, and Blood Institute, and so on. And data show that more than half of all funding is devoted to research on basic biomedical or behavioral mechanisms. That's the foundation for it. That's its core. And for those of you who've been involved in your own CTSA and the idea of translational research, you know that the model really begins with basic discovery, and through a winnowing cascade aims to translate what are often commercial products to FDA approval, whether they're drugs or devices. And although I think many people have tried to talk about bidirectional pathways, there's no question that the predominant pathway really is from basic discovery to then doing work with human subjects through the various phases of research, and then into effectiveness trials and even implementation trials. But it's very much a winnowing process. We look at the U.S. healthcare, and these are this figure of 4.3 trillion is on the CMS website, and the CDC estimates that 90% of our healthcare spending is on chronic diseases and mental health. I realized it was high, but when I saw that figure, I was it was even higher than I had anticipated. Those of you who work in healthcare know that healthcare payment requires billing for codes for diseases. These are called ICD-10 codes, the International Classification of Diseases. So if you don't have a disease to code for, in most cases, you can't bill. You also need what's called a procedure code, current procedural terminology, CPT codes to deliver. And these are mostly done through physician-driven encounters. That's the nature of our system now, whether those encounters occur in an outpatient, in a practice, in an ambulatory specialty, or in the hospital. Clinicians, including physicians, need to bill for a procedure at one point in time. And the mean spending per person, this is not per household, this is per person. So this includes whatever it is, 333 million people in the United States. The average spending is at about $13,000 a person, and accounts for getting close to 20% of the GDP. And similarly, more than 18% of the non-elderly spend more than 10% of their total household income on healthcare, and this has risen 27% over the years that AHRQ has been tracking it. So the thesis of my talk is that really the biomedical model alone is insufficient for addressing either health through research or for the provision of healthcare in the ways that most people want it delivered. In terms of research, the biomedical model really applies a very restricted lens or scope, because it ignores the positive aspects of health that are important to people and communities, including agency, resilience, adaptability, and well-being. That doesn't mean that none of the research touches on that. It just means that the predominant paradigm that's being used is biomedical. And as I mentioned, it begins with basic mechanisms that may or may not ultimately translate into any health benefit over the estimated 17-year timeline, rather than research that addresses the determinants of health, which is very hard to get funded. Although there are some FOAs coming out more recently, it's a very small portion of the total budget. And of course, research undergirds a pipeline that's largely for the biotech industry, approval of devices and pharmaceutical agents and biosimilars, while failing to invest at least commensurately in community-driven health equity research and in people themselves. In other words, a core distinction between the biomedical model is that one is doing something to people rather than investing in people and enabling people to be healthier. That's the fundamental difference in that paradigm. And of course, it's exceptionally expensive. We have double the mean spending per capita compared to other rich countries. We have the highest out-of-pocket costs that often can be financially toxic and can become a social determinant of itself when somebody becomes bankrupted because of their hospitalization that they couldn't afford. And we now have the lowest uninsured rate on record, and thanks in part to the Public Health Emergency Act, but we're still higher than any other high-income country. And the model really fails to ensure a health equity, and I'll talk a little bit about that. So if we want to look at the data as sort of a test of the biomedical model, look at its impact during vulnerable life stages. And we start with maternal mortality. What you see here is just an extraordinary gap between other rich countries. There's Netherlands at 1.2. And I think these are per 100,000. And among Black women in the United States is 55. But even the lower line, which refers to white women, is way over anything in these other countries. And that includes European countries. It includes Korea and Asia, New Zealand, as you can see. And as you saw there was a big gap in by race in maternal mortality. But what you see here is that it hasn't always been such. If you go back to 1969, the rates were very high. There was a huge gap between Blacks and whites in the bottom here. That reached a nadir sometime in the mid 1980s. But since that time, there's been a steady increase in both, but also a widening of disparities between Black and white women dying within 6 weeks of giving birth. This is a similar graph, just looking at quintiles of SES or income, and a very similar pattern with very high rates back in between around 1970, a nadir, depending on which group you look at, somewhere between the mid 1980s and the early 1990s, with a steady increase and almost a reversal. You look at infant mortality, which has been a long time measure of population health, you see that we were actually leading rich countries back in 1960. We crossed over sometime around a little in the early 70s, and now we trail other OECD or rich countries. And of course, as many of you know, there are persistent racial inequities in infant mortality. Here you have the white group, which is near the one of the best. Asians slightly better than whites, with African Americans having the highest rates, both in 2019 and recently in 2020, with only slight change, followed by Native Hawaiians and other Pacific Islanders, and then American Indians and Alaskan Natives. Hispanics are a little bit higher than the white group. I think the COVID-19 pandemic really provided a national stress test for our population health and our ability to respond. And I suspect these data are not going to surprise many of you listening to this. This is a life expectancy. Again, these are the comparable rich countries. This is done by the KFF Peterson tracker over time. And as you see, even back in the early 80s, we did trail the average. We were still in the pack, each line representing a country. And then it began to diverge over time until the COVID pandemic. And then with the COVID pandemic, what you see is that other rich countries did see a slight dip from a mean of 82.4 years in their life expectancy. And of course, we saw a huge drop. And when you begin to disaggregate this by race and ethnicity, what you see is that the biggest impact was on Native American and Alaska Natives, with a drop of 5.6 years in life expectancy. I mean, that's extraordinary. That is rare in public health, where you see that kind of impact outside of a massive war. I mean, that is or a very severe pandemic. For the Hispanic group, it's 4.2 years. For African Americans, 4 years. And then 2.2 for Hispanics, and Asians very close at 2.1. The huge drops for all groups, with huge amounts of inequity. Much bigger inequities that we're seeing in other countries as well. So I think it's clear that the biomedical model, both in terms of the research that we really need to inform how to help people become healthier, as well as a healthcare delivery, is really by itself not sufficient. I think people thrive when they live in conditions in which their material, physical, developmental, psychological, social, environmental, and spiritual needs are nurtured. I think that is almost common sense, and I think many people off the street would agree with that. And that health inequities emerge when people live under conditions in which these fundamental needs are thwarted. So a big question is, why the divergence? So we were doing well in the 60s, and we crossed over sometime between 1970 and 1980. What happened during this time to cause this national decline in health in the United States? So this is these data were from the Washington Post by Gabrielle Zuckman and Emmanuel Saz, who's done a lot of work on income inequality, both in the United States and internationally. But what you see is the black line here is the top 1%, the red line is the middle 40%, and the blue is the bottom 50%. And as you can see, it's very flat over these time periods, whereas in the early 80s, income among the top 1% just skyrocketed, and this is after tax and transfer income is taken into account. And many scholars have looked at this, and I think there is certainly, I think one could argue, particularly for sure on the left, and probably even among many mainstream scholars, that neoliberalism really has really had a huge impact Neoliberalism, the term is often not used that often in the United States, but it really refers to a set of political and economic policies, based on ideology that really reflects, I would say, weird culture, focus on the individual, autonomy and freedom. But, deregulation, particularly of large companies and industries, privatization, often of public goods, healthcare, education would be prime examples of free trade, globalization, tax cuts, and austerity that often results in significant reductions in social spending. And of course, neoliberalism became popular in the US and many other countries, both in Europe as well as Latin America and elsewhere. Margaret Thatcher, of course, was a champion of neoliberalism. And in fact, neoliberalism has been championed by both Democratic and Republican leaders and presidents. And certainly the timing of these policies aligns well with declining health in the United States. And if you think about it, deregulation certainly undermines health in all policies. If you think about policies on food or policies on transportation, policies on access to expanded access and insurance for healthcare, you can go on. And if you move to deregulation and a laissez-faire, more capitalistic approach, you are going to, on average, harm population health with a disproportionate or disparate impact on lower people with less income and other social disadvantages. And of course, income inequality and the privatization disrupt social cohesion and equitable access to resources. And many people have written about that. Richard Wilkinson, most of his books have focused on that whole concept that that among weird cultures or weird countries, that they've hit that epidemiologic transition where it's all about chronic disease. And at that point, the impact of income inequality and how people compare themselves to others really erodes social cohesion and undermines well-being and health. And of course, reductions in social spending and welfare and investment in people, particularly those most disadvantaged, have obvious impact. And many of you probably have seen many studies suggesting that social welfare policies can have a much greater impact on population health than does healthcare itself. McCartney and others have done a systematic review of reviews. So they took other systematic reviews and pulled them all together. This was published in the American Journal of Public Health in 2019. And concluded that neoliberal restructuring seems to be associated with increased health inequalities, higher income inequality, with lower self-rated health and higher mortality. So there is considerable empiric evidence that neoliberalism harms health. Another group looked at the impact of neoliberalism in Canada and the United States, since they both adopted neoliberal policies, and looked at many of the factors at why the impact was greater in the US. And you can imagine some of the reasons that included greater social cohesion in Canada, much stronger safety net structure, including universal health care and social policies that helped to mitigate some of this. And probably some of the policies were not quite as harsh. Many of you have probably seen this definition attributed to Albert Einstein. Actually, it wasn't Albert Einstein. There's no evidence that he ever said it. But it does appear in a passage by the novelist Rita Mae Brown, her novel called Sudden Death, which was about a love affair between two women, one of whom was a famed tennis player, and that's where the term sudden death came from. And one of the characters said insanity is doing the same thing over and over again, but expecting different results. And probably Rita Mae Brown probably got it from at the Al-Anon movement that comes out of one of the steps. Another way of looking at this is what Paul Krugman calls zombie ideas, which he defines as beliefs about policy that have been repeatedly refuted with evidence and analysis, but refuse to die. And as you can see, he wrote a whole book on the topic. And I would suggest that the biomedical model is by itself is that should be inadequate to generate health research and deliver care as a zombie idea. That this idea that it can do it, it really doesn't make sense. We've been trying now for more than a century, and if anything, everything is going in the wrong direction. So why does it persist? Well, it certainly has had remarkable biomedical successes. I had a ruptured appendix when I was in Haiti and didn't realize I had it, made it back to the United States and recovered. It was a slow recovery. I was quite sick, but I could imagine had I not had access to biomedical technology, I might not have made it. I've practiced HIV medicine all my life. And early in my career, of course, the hospitals were filled with people dying of AIDS. And then when combination therapy was developed, the first protease inhibitor to treat HIV was developed. I think it was in around 1996. Everything changed. And really, people's lives were totally transformed. And of course, much of the work around antiretroviral therapy came out of NIH. So there clearly have been remarkable biomedical successes, and many of you can name more. And that certainly contributes. I think there's no getting around that entrenched interests and profits have had a huge impact. This is Paul Starr's on the transformation of American medicine, and Barbara Ehrenreich's report from 1970, which I read, I think, before I even went to college. That was very powerful. Societal culture, and Joseph Davis has written a whole article on this. But you can imagine the cult of hyper-individualism in the US. We rank the highest among rich countries on Hofstede's measure of individualism. So we are really a hyper-individualistic culture. The cult of commodification, everything being commodified, including in healthcare and now lifestyle medicine, exercise, denial of our shared humanity and needs. You know, as long as we're using a mechanistic model, we don't really have to think about what it means to be human and what people need to thrive. And of course, the cult of life extension and immortality, the idea that we will have a magic bullet from biomedicine that will allow all of us to live to be hundreds of years old. The model is really an invisible culture. I got interested in this and decided to search for definitions. So I searched on Google and Google Scholar. I looked at all the glossaries because all of these agencies, HHS, NIH, CMS, CDC, all have websites, all have glossaries. I used ChatGPT and Bing chat searches at the time. And I reached out to the communication office at each of these agencies. I couldn't find a definition. The web searches were unsuccessful. ChatGPT indicated that these three agencies do not define health. They did indicate that the CDC uses the 1948 definition, but their citation appeared to be a hallucination. I could not track it down. It may have been true at one point, but I could not find a current definition. And most of the communication offices failed to respond to my inquiry, even when I told them what I was doing. The CDC did reply, but told me just to check their website, but did not give me a citation. Well, do other countries define health? If you go to Canada, you Google it, you'll find it very quickly. They use the both the 1948 and the Ottawa Charter on Health Promotion is right there. So there really is a conceptual void because we don't define it. We ratified the WHO Constitution, which presumably included the definition, but we've ignored it. And really, the absence of this explicit definition really helps perpetuate an implicit biomedical definition. It also means that health equity is defined based on the absence of disease and means that it should be addressed only biomedically. And of course, we all know that if you don't address social determinants of health, you'll only get so far. So what do we need to get it to a national definition of health? Well, as I've done this work, I've realized that there are a few rays of hope. This is from the Center for Healthier Children, Families, and Community, led by Neil Halfon. They've developed what's called the gross developmental potential, which is a developmentally driven capability-based measure of human potential at the earliest phase of life. But I think their plan is to really scale this out across the life course. And they've been doing a lot of work with in conjunction with RAND. And you look at some of their core developmental capabilities in this GDP2, as they call it. You can see a lot of them have intuitive appeal, living healthy lives, satisfying basic human requirements, communication, expressing and understanding thoughts and feelings, lifelong learning, again, adaptation to change, connecting with others, and community engagement. Similarly, the Robert Wood Johnson has had an initiative probably going on now for probably getting close to a decade now, called Building a Culture of Health. Now, most of their focus has been outside the healthcare system. I haven't talked to them and asked them why, although it does not exclude the healthcare system. I think they feel like perhaps they can make a bigger impact on the community side. The VA has nearly a decade-wide initiative called Whole Health, and this appears on their website. And their mantra is, what matters to you, not what's the matter with you. And then very recently, and this book is available on the National Academy's website, free. You can download it for free in the PDF form, entitled Achieving Whole Health, a New Approach for Veterans and the Nation. And it defines whole health as physical, behavioral, spiritual, and socioeconomic well-being, defined by individuals, families, and communities, and requires an interprofessional team-based approach anchored in trusted relationships to promote well-being, prevent disease, and restore health. And in the report, they list the foundational elements, which of course sound very primary care-like, people-centered, comprehensive, and holistic upstream focus. So you're addressing the social determinants higher up, equitable and accountable, and ensure team well-being. I think there's key advantages to defining whole health in this way. It avoids the risk of protracted debates on the meaning of health. And I think I could imagine that people could be concerned about that, given the multi-dimensions inherent in the concept and how people value these differently. It potentially jumpstarts implementation, that as it's done in the VA, although it has not yet been scaled throughout the entire VA. And the definition is intrinsically people-centered, and that it really takes the idea of patient or people-centered care very seriously. Of course, this concept's been around for more than 20, probably 30 years now, but we've really had a difficult time operationalizing it within a biomedical paradigm. I think there's also some risk to defining it. It implies that health and whole health are fundamentally different, and risk compartmentalization in a similar way that primary care has been a little bit compartmentalized from the larger healthcare system, it skirts a difficult conversation on the perpetuation of the biomedical model. And with so much money being spent on biomedical research and on healthcare, it's not clear where the funding would come to really scale whole health research. Perhaps we could take a complementary approach. Personally, I think it does make sense to move ahead with the recommendations in the NASAM report on adopting whole health, but while also having conversations and multiple conversations around what health really means to different people and whether we can converge on a multifaceted definition. Obviously, this means bringing to the table diverse communities, whether diverse in many different ways, including culture, background, SES, urban, rural, etc. And then once we have a definition, having some really serious thoughts and discussions around what it would really mean to operationalize it across healthcare, and health research agencies and vendors. And certainly, research is going to be absolutely critical in sort of providing the evidence space to do this efficiently and equitably. And fundamentally, this would inform research related to investment in people and communities, how we create those conditions that nurture all of us. And ultimately, we probably need a complementary NIH translational continuum that really starts with community engaged research regarding these strategies and then looks backwards at what other evidence is needed. But rather than starting with basic mechanisms, we start with what those health priorities are and really adequately fund that in order to address the social, behavioral, and environmental determinants. And of course, for health equity, we know that, and I think most people, when they use the term health equity, mean much more than just the incidence and treatment of diseases, that it includes aspects, the facets of well-being that we've been talking about, but even more fundamentally, that it relates to a human development, human potential, nurturing all our needs and enabling us to have a capability for health and healthy lives. And I see that we are getting near the hour, so I will stop then and take any questions, but thank you all for listening.
Kevin, I want to thank you for a really wonderful presentation that I think resonates so much for many. Well, I won't speak for myself, but for myself, and I think many of us, I suspect also who work in family medicine and work in our department and think about the implications of health and research for our patients and communities. Since we are so close to the hour, to the end, I wanted to give you the chance to just wrap up with maybe one concluding thought to leave us with. If you had to leave us with one take-home question or words of inspiration as we head off to clinic now and for the next, hopefully, decades of working together as a team to address some of these challenges and think about what the definition is of health and how it impacts us all, including our patients and communities, what would your words be to us?
My one suggestion would be to engage other people in conversation around what health means to them. If you're a clinician, that could include patients, because that's a good way of bringing on what matters to you and what matters to you in terms of your health, since that's what they're there for. But also with your friends and families and neighbors, and really get that conversation started around what health means and how we might thinking about getting to coalesce around having a national definition. It's kind of ironic and shocking that we have health agencies like Health and Human Services and the National Institutes of Health that have health in their very name, yet none of them seem to have a definition that is widely circulated, if they have one at all.
Muted there. Thank you. This has been a wonderful talk. And I think I will say for me personally, you've caused me to look a lot deeper at words like health that we use every day and take for granted. And I I suspect that you're going to be the genesis of a lot of deep thought and conversation for our department, and again, hopefully our providers and patients, staff, and community. So I want to thank you for your work and for joining us today. Have a wonderful afternoon, everyone. Thanks for being here.
Thank you for having me. Bye-bye.
Bye-bye.